Okay, well, so we're going to be talking about the mechanisms of action in rhegmatogenous retinal detachment. Roxanne Hillier is my co-chair, and we see this esteemed panel who have published greatly on various topics that we're going to discuss today. So I'm just going to start by talking about what is integrity in reattachment. What are we referring to exactly? When we see a patient with a retinal detachment, superior with several breaks, there's many ways that we can fix this. We all know that all of these techniques work very well. And this patient was 3 months after a detachment fixed with vitrectomy. Visual acuity was 20/25, and we've told the patient they've done fabulous. But when we look at it in more detail, we see that the patient had severe anisoconia. Objects were much smaller. And we've had this historical focus on single operation reattachment. This is our only main goal. But we have to now start thinking about functional outcomes because that's what's most important for our patients and for us. So reattachment is really the basic requirement. Putting the paint on the wall or the wallpaper on the wall, that's the basic requirement. We need to think about the quality of the job we're doing, the integrity of the attachment, and then we can maximize functional outcomes. We talk about this wallpaper analogy, and we don't want to just put the wallpaper on as quickly as possible with one procedure. We want to do it well. We want to minimize stretching and folding. And that's really the underlying concept of what we're going to be talking about today. So I'm going to start by discussing the importance of outer retinal corrugations. When you look at the retina with imaging, you can see these undulations in the outer retina that are deep, and we can confirm this with swept source OCT and see these beautiful corrugations in the outer retina. These are related to subsequent outer retinal folds, and we're going to talk about this in a lot of detail today, so I'm not going to go into it a lot. But what we're going to talk about is the pathophysiology. If you understand corrugations, you're going to understand so much more about retinal detachment and its repair. So let's start by looking at cases where you don't get corrugations. So for example, you have a small detachment, localized, you don't get corrugations, even after an extended period of time. It doesn't involve the fovea. You never get corrugations in the fovea because the Mueller cell cone acts as a rigid scaffold there to prevent that. But you do get it in the parafovea and in the peripheral retina. What about chronic, shallow, subclinical detachments? We also don't see outer retinal corrugations in these cases because the fluid is different. Also, it takes time. So if you have a bullous extensive detachment, you won't get corrugations until after 2 days. And this is related to changes in the elasticity of the outer retina that happen over time. What if you have a bullous detachment that's exudative? You also will not get corrugations. Again, the nature of the fluid is very different. What about a patient who had pneumatic retinopexy with corrugations and we treat it? And we'll see that as soon as the bubble goes in and the fluid starts to resorb, these corrugations gradually improve and go away. And if you have residual fluid, you also will not get these outer retinal corrugations. So with our engineering colleagues, we determined that to get corrugations, you need a change in the ratio of the elasticity of the outer retina to the inner retina, such that there's a reduction in the outer retina. And so if we look at the pathophysiology of outer retinal corrugations, you can use this mnemonic, SLEPT. It's size-dependent, location, it's foveal sparing, it requires an acute exposure to liquefied vitreous, you need a loss of pump control, and it takes at least 2 days. So I'm going to show you this animation video that demonstrates how this is happening. You get a retinal break, subretinal fluid goes under the break and causes a hydration of the outer retina. This hydration leads to an expansion, a thickening and a lateral expansion. So now you have more tissue in the outer retina relative to the inner retina. This leads to compressive forces, and with that change in modulus of elasticity, you get these outer retinal corrugations. So this is very important, and we're going to talk more about it because the way that you attach the retina will impact the integrity of the attachment based on how you deal with this. So in conclusion, to get corrugations, you need RPE photoreceptor regulation. You need, these outer retinal corrugations can lead to outer retinal folds and poor integrity, and understanding outer retinal corrugations will really impact management. Thank you very much.
Only one part of the morphological changes that happen to the retina. And so last year we published a prospective study on 49 consecutive patients in which we described for the first time the sequential morphologic changes that happen to the outer retina. And we used posterior pole and ultra-wide field swab source OCT, and we assessed the retina along the direction of the RD progression from the peripheral break to its leading edge. And we found that there are 5 stages of retinal detachment. And so stage 1 is the separation of the retina from the RPE with no apparent changes to the photoreceptor layer, and it occurs at the edge of the detachment, followed immediately by stage 2, where there's a thickening of this bacillary layer. Then we progress to outer retinal corrugations, initially low frequency, low amplitude, progressing to high frequency, high amplitude. As time passes, these corrugations will lose definition in stage 4, and finally in stage 5, there's a patchy then complete loss of photoreceptor inner and outer segments. And here's an animation video showing all stages together. So again, we have stage 1 at the junction of the attached and detached retina, followed immediately by the thickening of the bacillary layer. Then we have mild undulations and high-frequency corrugations in stage 3. And as time passes, these corrugations will lose definition. And finally, in stage 5, we have that moth-eaten appearance of the outer retina with a bare external limiting membrane at the end. And so this year we decided to do a larger retrospective cohort study to assess the validity, the clinical validity of our staging system, and we included 351 consecutive patients. We used baseline swab source or spectral domain OCT. Visual acuity was obtained at presentation 3, 6, and 12 months, and we excluded visually significant cataracts. And now our main outcome was the association of the stages with 12-month visual acuity. And what we found was that increasing stage was significantly associated with a longer duration of vision loss, as well as with a worse baseline visual acuity. And now from our primary outcome, increasing stage was significantly associated with worse post-operative visual acuity at all time points, at 3, 6, and 12 months, even controlling for time to surgery, type of procedure, baseline visual acuity, and duration of symptoms, duration of vision loss. But we know that obviously detachments of several weeks can do worse, but what about acute detachments? So we tried to do a subset analysis only in acute detachments, meaning those that had loss of RPE control, as Dr. Mooney discussed, acute, extensive, and progressive RD. So we excluded subclinical, chronic, and slowly progressive detachments that had that flat configuration on imaging or had 4 or more weeks of vision loss. And what we found is that 12-month visual acuity is no different between early stages 1 and 2 when compared to stage 3A. However, visual at 12 months is significantly better in stages 1, 2, and 3A when compared to stage 3B, and also when we compared adjacent stages 3A and 3B. So this suggests that stage 3A to 3B might be a critical transition point where significant structural changes happen to the retina, leading to worse outcomes. So what I want you to remember from this presentation is that the morphologic changes of the retina can occur in 5 stages. An increasing stage is associated with a longer duration of vision loss and worse post-operative visual acuity. Therefore, urgent intervention in stages 1, 2, and 3A may be beneficial for our patients.
Most of the information we have on this comes from studies done by Robert Muckerman in the 1960s in owl monkeys. But because we do pneumatic retinopexy, we've been able to study reattachment in vivo in humans as it's occurring. And we've devised a staging system for how the retina reattaches over time. So take this patient with a macula-off retinal detachment. Initially, you see some cystoid macular edema and corrugations. When we put the bubble in, there's a redistribution of fluid. In stage 2, look at the corrugations in the CME that go away. In stage 3, you get contact of the retina with the RPE. In stage 4, there's a deturgescence of the photoreceptor layer. And in stage 5, you get recovery of the outer retinal bands from the ELM to the EZ to the interdigitation zone in a very predictable manner. So here's another animation video demonstrating this. So initially a baseline appearance, redistribution of fluid in stage 1. See the CME and corrugations go away in stage 2. This is very critical. In stage 3, there's contact of the retina with the RPE and then a deturgescence of the photoreceptors in stage 4. You then get recovery from the ELM to the ellipsoid zone to the interdigitation zone, followed by the foveal bulge. Now, if you have a delayed recovery or progression through stage 2, you can get these outer retinal folds, and if you have a delay progression to stage 3, you can get residual subfoveal fluid blebs. Subfoveal fluid blebs can be beautifully seen with en-face OCT, and here you can see how the subretinal fluid gradually reabsorbs over time. This is a patient with an inferior dialysis who had a pneumatic retinopexy. Here you can see over time that the fluid is naturally reabsorbing over time by occluding the retina or tamponading the break. And you see this subfoveal fluid and subretinal fluid that gradually reabsorbs over time, just like puddles drying up in the sun. And you can see with this time-lapsed en-face OCT video how the fluid nicely resorbs. And sometimes it can take a long time, up to 6 to 9 months. But what we found is that visual acuity, although it's initially lower when you have subfoveal fluid blebs, it always catches up, and it doesn't seem to compromise outcomes in the long run. Thank you very much, and I'd now like to introduce Wei Li, who's
on outer retinal folds, which is a microstructural abnormalities that can occur after an RD repair. I have no financial disclosures. In this talk, we are going to learn what is the best way to detect outer retinal folds, how does it impact our patient, understand the pathophysiology of outer retinal folds, and using that, find ways to reduce outer retinal folds. I'm going to start with a case that we see day to day in our retina clinic, a patient with a macula of retinal detachment. A month after RD repair, retina is attached, but patient's vision is 20/60. And when we take a look at the macula, there were no gross abnormalities seen. But as we take a closer look at the en-face and cross-sectional OCT scans, we found that there were presence of hyperreflective curvilinear line, and this corresponded with the protrusions seen on the cross-sectional scans. So these are outer retinal folds. Outer retinal folds were first described by Benson et al. In 2006. Subsequently, Delamo and Peretti demonstrated that incidence of outer retinal folds were fairly high after vitrectomy, and that they were associated with worse functional outcome. So our group performed a post-hoc analysis of the pivot trial, looking at incidence of outer retinal folds after vitrectomy compared to pneumatic. And we found that incidence of outer retinal folds was significantly higher after a vitrectomy at 34.1% compared to 14.3% after a pneumatic. So what is the best way to detect an outer retinal folds? It is important to note that different segmentations of OCT results in varying outer retinal folds appearance. In the easy segmentation, outer retinal folds appear as a wider hyporeflective lines, as representing the area devoid of EZ as EZ is folded to form the outer retinal folds. In the RPE segmentations, outer retinal folds appear as a fine hyporeflective line, representing the shadows of the outer retinal folds. But in our customized slab, outer retinal folds appear as a hyperreflective line, and these prominent lines aids us in detecting the outer retinal folds. So our customized en-face slab extend from the junction of outer plexiform outer nuclear layer to the junction of myoid and ellipsoid zone. These are serial OCTs of 2 patients demonstrating resolution of outer retinal folds with time. Although outer retinal folds resolve with time, in this study, we learned that presence of outer retinal folds were associated with worse ETDRS letter score at 1 year. So the difference, patient with and without outer retinal folds were different by 9.4 ETDRS letters. And when we perform a sensitivity analysis on the vitrectomy group alone, the difference was 12.6 letters. So in order to understand the pathophysiology of outer retinal folds, we have to go back to histology study, where McCammon et al. First described outer retinal corrugations. Decades later, Delvin et al. Demonstrated similar findings on OCT and termed them hydration folds. Delamo et al. Was the first to describe that outer retinal folds originates from these outer retinal corrugations. So we learned earlier in the staging system that if there is insufficient time for the outer retinal corrugation to resolve in stage 2 before it touches the RPE in stage 3, this can lead to the formation of outer retinal folds. So in the vitrectomy, during air fluid exchange, fluid is actively drained from the subretinal space, and retina is reattached immediately. There is insufficient time for the outer retinal corrugation to resolve before it touches the RPE, leading to the formation of outer retinal folds. Comparing this to a pneumatic, where after a gas injection, patient is required to alter head position to position the bubble over the brake, and subretinal fluid is slowly reabsorbed by the RPE pump. These are serial OCTs of a patient after pneumatic. There is sufficient time for the outer retinal corrugation to resolve before it touches the RPE. Therefore, there are no outer retinal folds formation. So the take-home message is that outer retinal corrugation needs to resolve before retina is reattached. Therefore, a slower, more natural reattachment is better than a faster, forceful one. In order to reduce the incidence of outer retinal folds, we need to consider RPE pump-based procedures, for example, sclerobuckle or a pneumatic retinopexy, or even modification of surgical techniques to reduce the incidence of outer retinal folds to achieve a better functional outcome for a patient. Thank you.
Okay. So anomalous PVD can be associated with vitreoskisis, and vitreoskisis can result in some remnants of vitreous of the cortex vitreous very tightly attached to the retina. These cortex remnants can be found at the macula or at the periphery in about 70% of cases with the primary rhegmatogenous retinal detachment. These VCRs are very important because they have been associated to primary reattachment failure in a patient with a rhegmatogenous retinal detachment and also with the development of macular pucker. In this lecture, I would like to focus on the potential influence of VCR on retinal integrity, focusing on two main aspects, the unintentional retinal displacement and the formation of outer retinal folds. Regarding the retinal displacement, we thought that removal of peripheral VCR could impact on the displacement because removing the VCR, we can make the retina more mobile. Because as you can see from this video, the VCR are very, very strongly attached to the retina. So making the retina more mobile can signify reducing or promoting the displacement. But actually, putting together a lot of factors, we found that the only one that was significant to induce displacement was the use of gas. As previously noted in other publications and also reiterated by a recent mathematical and computer-based model by the group of Dr. Mooney. Regarding the influence of macular VCR on outer retinal folds, again, we thought that making the retina more elastic at the macula can have impact on the rate of post-op outer retinal folds. We know that outer retinal folds form in correspondence of outer retinal corrugations, and some surgical technique like vitrectomy can favor the formation of outer retinal folds because we force the retina to reattach using PFCL or high-tension products like gas. We also know that the stiffness of the attached retina regarding the inner and outer layers is different from the stiffness and the elasticity of the outer retina and inner retina when the retina is detached. And Dr. Mooney work team has taught us that there is a ratio between the elastic modulus of the inner retina and outer retina that it's very important to consider it when we study the outer retinal corrugations. So we thought that looking at the inner retina too could be important. And actually, we noticed that some preoperative biomarker on OCT can be very useful and highly specific to find then macular VCR intraoperatively, like this sawtooth aspect of the retinal surface. Another biomarker, POP biomarker on OCT that can be highly sensitive but poorly specific is the presence of this pre-retinal hyperreflective layer. So the question is, can the macular VCR increase the stiffness of the inner retina and play a role in outer retinal folds formation? I show you two cases. In the first one, there is a presence of outer retinal corrugation pre-op. There are no pre-op biomarker on OCT of macular VCR, and actually we didn't find macular VCR intra-op this patient had PPV and tamponating with SF6 20%. We do not have any post-op outer retinal fold. In this case, we have both the sawtooth aspect of the inner retina, we have pre-retinal hyperreflective layer, and we have outer retinal corrugation. In this patient, we found macular VCR, but we didn't remove them. And after operation, we see the outer retinal folds and this corrugation of the inner retina. And also putting several factors together in a multivariable logistic regression analysis, we found that both the presence of macular VCRs and their removal were significantly associated with the presence of outer retinal folds. So in conclusion, peeling of peripheral VCR does not have an impact on retinal displacement, but might reduce the detachment rate due to PVR, and peeling of macular VCR may reduce the occurrence of outer retinal folds. We don't know if this can reduce the post-op metamorphopsia or increase the post-op visual acuity. Thank you.
Thank you for the introduction, and thank you for the opportunity to speak here. My name is Natalia Figueiredo. I'm going to talk about assessing post-operative photoreceptor recovery with unfast OCT. I have no financial disclosures. I'm going to start with a real case. A patient comes to your office presenting with a successful anatomic reattachment after a macula of Rhegmatogenous retinal detachment. The retina looks great and it's fully attached, but the functional outcomes, including visual acuity, they are reduced and the patient is unhappy. So let's look deeper. We can, looking deeper to the cross-sectional B-scan OCT, we can see that the EZ shows abnormalities, but it is hard to get a sense as how extensive it is. We decided to explore the photoreceptor recovery with unfast imaging, and analyzing the unfast image of the ellipsoid zone slab, we could observe an extensive hyperreflective region. Then, we wanted to explore this formally, so we did a post-hoc analysis of the pivot trial. We used the default ISOS automated segmentation from the Zeiss software. Here's an example of this segmentation and its unfast image to the right. The aim of the study was to quantitatively assess EZ recovery using unfast OCT and to determine the correlation between EZ recovery and visual acuity improvement. We analyzed unfast images of the ellipsoid zone slab, and the hyperreflective regions, they were assessed quantitatively. Over the 181 images analyzed, a statistically significant reduction was observed in the mean area of hyperreflective over time from 3 to 24 months. And as the measured area of EZ hyperreflectivity significantly declined, the ETDRS letter score improved. To sum up, EZ recovery can be quantitatively documented after Rhegmatogenous retinal detachment surgery using unfast OCT images. A steady reduction in the area of abnormal ellipsoid zone was observed over time and correlated with visual acuity improvement. And hyperreflective areas on unfast OCT may serve as a useful biomarker for EZ integrity. So going back to the patient that we showed in the beginning of the presentation, we can see a gradual reduction over 2 years time from 3 to 24 months. And as the measured to 24 months reduction, they were assessed quantitatively. Over the 181 images analyzed, a statistically significant reduction was observed in the mean area of hyperreflective over time from 3 to 24 months. And as the measured area of EZ hyperreflectivity significantly declined, the ETDRS letter score improved. To sum up, EZ recovery can be quantitatively documented after rhegmatogenous retinal detachment surgery using unfast OCT images. A steady reduction in the area of abnormal ellipsoid zone was observed over time and correlated with visual acuity improvement. And hyperreflective areas on unfast OCT may serve as a useful biomarker for EZ integrity. So going back to the patient that we showed in the beginning of the presentation, we can see a gradual reduction over 2 years in the hyperreflective region. However, we still find it at 24 months. And in the study, the long-term follow-up assessment identified a significant reduction of the hyperreflective area over a period of at least 4 years, as shown in this image. The unfast OCT scan has also the advantage of demonstrating the entire area of EZ hyperreflectivity in a single image, and it can be reassuring for the patient to see the recovery over time. Finally, the longer the duration of macula off detachment, the less the improvement was found in EZ hyperreflective areas. To conclude, EZ hyperreflective area on unfast OCT represents a quantitative assessment of photoreceptor integrity. This imaging biomarker is correlated with long-term visual acuity outcomes. The duration of macula off detachment impacts the speed of photoreceptor recovery, and photoreceptor recovery can continue over a period of at least 4 years and likely longer. Thank you.
I'm now going to talk about mechanisms in retinal malapposition, including retinal displacement. So let's go back to our patient who had severe anisoconia despite good visual acuity. If we look at the fundus autofluorescence, we see these hyper-autofluorescent lines indicating the location of the retinal vessels before the detachment, and we can see that the retina has shifted. This is a patient following pneumatic where we don't see those hyper-autofluorescent lines, where the functional outcomes were better. So with a multi-center study group, we assessed the risk of retinal displacement, and we found a 50% or 45% risk in the vitrectomy group, which is consistent with the literature out of Japan, out of Italy, out of the UK. But what was different was that the risk of retinal displacement is significantly less with pneumatic retinopexy at 7%. We followed this up with a prospective clinical trial which corroborated these findings with the same risk in the fovea off group in the macula off patients who had vitrectomy versus 14% in the pneumatic group, again showing a significant difference. We also recently completed a study comparing buccal versus vitbuccal, and again found that in the vitrectomy group there was a significantly greater risk of retinal displacement. So why does this happen? Well, we know that there's always some subretinal fluid that's left behind at the end of surgery. This subretinal fluid gets displaced by the buoyant force of the large gas bubble, and as this fluid is displaced inferiorly, it stretches the thin elastic retina, leading to retinal displacement. Now, while we were trying to figure out exactly what was going on, we thought, okay, let's be smart here. Let's inject perfluorocarbon liquid and avoid the air-fluid exchange and avoid the gas altogether. So we shouldn't get any displacement if it's due to the tamponade. If you see here, we're putting in the PFCL very slowly, and you can see the fluid going infratemporally. That's very important. We got the worst displacement we've ever had. And why? Because we then understood that it's not the specific technique, but it's the fact that we're moving fluid. When you iatrogenically displace fluid, you're going to get retinal displacement, whether it's PFCL with an endotamponade, whether it's a gas bubble, or whether it's even scleral buccal with drainage. When you drain with a scleral buccal, again, you're forcing fluid to move in a certain direction, and then when the drainage stops, it stops when it's stuck to the buccal, and it stays in that stretched position. I want to take a minute just to differentiate slippage versus displacement. We know that when we have a giant retinal tear, for example, we inject perfluorocarbon liquid, we flatten out the retina, we do our laser. There's always some anterior fluid that we can't get. Now, when we drain the fluid, we try to minimize that as much as possible, as much as we can, but we know that there's always a chance of that fluid migrating posteriorly. Think of slippage and macular folds as a redundancy in the retina posteriorly. When you have redundancy posteriorly, the retina has to be stretched anteriorly. So you have stretching anteriorly, redundancy posteriorly. That's what you get slippage and macular folds. Retinal displacement is the opposite location. You get stretching in the macula and redundancy in the inferior periphery where the fluid's been displaced. So what is the problem with retinal displacement? Well, we know that it causes anisoconia because it's stretching the macula. You have increased cone spacing, and that's why all your patients are going to say after vitrectomy that we see objects as smaller and pinched in. I want you to see this case of a supratemporal detachment. Here you can see in panel B mild retinal displacement, but in this case we had a FAF before the patient ever had a detachment, and if we overlay it, we see severe displacement temporally. That's much less on the FAF. And we know that we don't always have a FAF before the retinal detachment, but Kobe Brosh in Israel, one of our ex-fellows, developed this technique with homography, where if you happen to have an OCT before they got a retinal detachment, you can align the infrared images using RP and choroidal landmarks, and you can color code them, see the movement of the retina. And it turns out that 100% of vitrectomy cases have this shift of the retina and have this displacement. Thank you.
Thank you once again. So I've gone through the stages of detachment, but what happens to the fovea? So last year we started studying the fovea in detail in a prospective study with only fovea off detachments and baseline OCT, and we found that almost 24% of patients have evidence of bacillary layer detachment, with some having an inner lamellar hole that invariably progressed to a full thickness macular hole. So this year we decided to investigate the pathophysiology of secondary macular holes and detachments. We did a larger retrospective cohort study, including 360 patients, and again we confirmed that almost 23% of patients have ballot-related abnormalities in baseline OCT. 8% of our cohort had associated macular holes, but most importantly, 80% almost of these macular holes were actually ballot lamellar holes. And what are those ballot-related abnormalities we've been talking about? So we know that ballot is an introphotoreceptor splitting within the myoid zone, and here we have OCT scans demonstrating its abnormalities, and here in figure 1 we have a minimal split extending to a larger cavity in figure 2. In figure 3 we have the anterior disruption of the anterior ballot walls from this adjacent cystic changes, and finally in figure 4 we have the loss of the Miller cell cone, and then we have a result with the so-called ballot lamellar hole. And what seems to be the main reason why the fovea has such unique abnormalities is because of the intricate arrangement of the central atypical Miller glia, and these cells, they lack connection with the typical Miller cells in the foveal walls, and they have a watery cytoplasm. And all these distinct characteristics were hypothesized to impact on foveal stability and result in degenerative and tractional abnormalities. So with the assistance of histological sections of normal foveas, we started observing tissue disruptions very similar to those that we observed in the OCT, suggesting that our 4 areas of a low mechanical stability in the fovea, which are the RPE photoreceptor interface causing the detachment, the myoid zone leading to the ballot, the Henle fiber layers around the foveal walls, which leads to the disruption of the ballot walls, and finally the Miller cell cone and surrounding tissue leading to the ballot lamellar hole. And once you get a ballot lamellar hole, it will progress to a full thickness macular hole, either in the detached or in an attached state, and this is clinically relevant. Presenting with a ballot lamellar hole had worse visual acuity at all time points, even when we compare to ballot, to early ballot or ballot in different spectrum of the disease. So this is, just to conclude, our hypothesis is that outer retinal corrugations are formed as a compensatory response to compressive forces generated from dehydration and lateral expansion of the introphotoreceptor matrix. However, the Miller cell cone prevents the fovea from corrugating, which leads to a stretch in the cone bouquet and resulting in ballot. Once you get ballot, further damage to the anterior ballot walls from these adjacent cystic changes may result in instability and loss of the Miller cell cone, resulting in ballot lamellar hole. And then once the retina is reattached, the remaining bridge of introphotoreceptor matrix in photoreceptor segments will then degenerate, leading to a full-thickness macular hole. So in conclusion, we need to remember that almost 20% of RDs may have ballot abnormalities, and ballot is crucial in the formation of macular hole due to 4 areas of low mechanical stability, which is RPE photoreceptor interface, the myoid, the Henle fiber layer, the foveal walls, and the Miller cell cone. And once you get a ballot lamellar hole, you will progress to a full-thickness macular hole. Therefore, urgent intervention in ballot, in documented cases of ballot, may be beneficial. Thank you very much.
So I'd like to talk about the mechanisms of reattachment following scleral buckling and vitrectomy and how they may be similar in some ways. So building on my previous comments about outer retinal recovery, we've talked about how retinal recovery is rapid, forced, relatively turbulent, with bulk directional flow and displacement from a large gas bubble during transretinal drainage at the time of past plan of vitrectomy. Whereas with pneumatic retinopexy, the gas bubble is steamrolled to occlude the retinal break. And although you do get subretinal fluid evacuation through the break initially, as we alluded to, the final approach of the RPE to the retina is governed by the RPE. It's then followed by retinopexy. So, scleral buckling is a kind of magic, really. How do we achieve retinal reattachment? By approximating a scleral indent to an open retinal break, particularly if you don't drain. So there may be an element of reduced vitreous traction on account of the scleral indentation. Undoubtedly, the retinal pigment epithelial pump plays a role, but the bulk drainage of subretinal fluid or expulsion of subretinal fluid is a result of Bernoulli's principle of lamellar flow. This is the phenomena that's used in airplanes. This is a phenomena whereby the velocity of the fluid traveling up the indent, particularly on saccadic eye movements, which is why after a scleral buckle we encourage a patient to mobilize, results in a localized reduction in pressure, which encourages the fluid to egress through the retinal break. So both scleral buckling and pneumatic retinopexy share similar mechanisms: slow retinal reattachment, physiological drainage of subretinal fluid, relatively gentle evacuation of subretinal fluid, even if you do an initial drain, and less bulk directional flux of subretinal fluid than, say, for example, a vitrectomy. So we've talked about in vivo reattachment after pneumatic retinopexy, and what I have observed is a very similar course of events following scleral buckling. So this is a patient with a macular off detachment. You can see at baseline turgescence and some corrugations of outer retina with intraretinal cysts. 4 hours after placement of the band, remarkably, there's just a suggestion of some initial outer retinal recovery. 24 hours later, you see the subretinal fluid is clearing. This is a non-drainage technique, I should specify. I don't tend to drain. And you can actually see that the recovery is following the steps that we have discussed in the previous presentation, albeit each step is rather prolonged after scleral buckling. My experience in clinic is that we don't see displacement. We see good outer retinal recovery, but there is much less data after scleral buckling than there is after pneumatic retinopexy. So a meta-analysis has recently suggested that you get most retinal displacement after vitrectomy and perhaps least after a scleral buckle, but we really need more data. So scleral buckling may have the lowest rates of retinal displacement. Likewise, in the SPR study and recent meta-analyses, it's possible that you get the best vision after scleral buckle versus vitrectomy. However, I'm not sure cataract was fully accounted for, and again, we need some more contemporary data on scleral buckling, including multimodal imaging, to draw this conclusion. To summarize, buckling and pneumatic retinopexy share fundamentally similar mechanisms of action and may share the same advantages over vitrectomy. And this really means that while we gather more data, we as surgeons should be maintaining a very diverse skill set to make sure we give our patients the best functional outcomes. Thank you.
Hoover, yeah.
All right, so as I was saying, the anisoconia we were talking about is obviously not good, and we were introduced to this topic of drainage versus pneumatic, which is more gentle reapproximation of the photoreceptors, and we were thinking, what is it about the actual surgical technique which may cause it? Is it drainage itself? Is it the type of drainage? And so we wanted to look at this a little bit more closely over time. So when we follow patients just with vitrectomy for 2 years, we see that vision kind of restores within the first 6 months, and slight, variations thereafter, which we're all familiar with. And when we're looking at the reapproximation of the retina on the microstructural level, we see that, the retina is going to repair, but you still have these little pockets of discontinuity. And what does this look like over time? Well, the EZ and ELM will restore quite rapidly within the first 6 months. We see a significant change, but the interdigitation zone is a lot slower to reconstitute, and that may vary with technique as well. So we wanted to look at what technique, if any, is advantageous and what may hinder this. So looking at drainage through a peripheral retinal break versus a posterior retinotomy versus assistance with perfluorocarbon liquid. When we looked at and compared these three types kind of head-to-head, looking at 300 consecutive eyes, 100 in each group, we see that discontinuity of the ellipsoid zone and interdigitation zone were higher with PFCL use, and at 12 and 24 months, we see there's still more discontinuity of these outer retinal critical segments. And we see here is an illustration of some persistent microstructural changes, which we may be familiar with when we're looking at those on OCT. And what does this mean for vision? Well, visual recovery was actually better with drainage through the retinal break compared to PFCL, which was the lowest, and in the middle somewhere was drainage with the retinotomy. So when we kind of break this down a little farther, we did see more epiretinal membrane formation with the drainage retinotomy, which makes sense, that's already previously known, and there was a slightly higher amount of CME with the PFCL group. I'll just pass by those for time's sake. So in conclusion, there's less visual recovery seems to be inferior with PFCL use, as well it seems to be better or more advantageous to use drainage to the break when possible, and there's less ERM and CME with the drainage to the peripheral retinal break as well. And those changes in the OCT persist out to 24 months and seem to be higher with the use of PFCL. So PFCL, what is it about? Well, we've been talking about this already, but there is a posterior to anterior stretching of the retina, as well as a more forceful egress of fluid. And these photoreceptors are likely already very friable, and so if you're rapidly approximating them, you would think they'd incur some more damage than when there's a little bit of fluid left. So what about non-drainage or minimal drainage? Well, we're kind of starting to discuss this. Anatomical success rates seem to be normal, or at least similar between the two, and so it doesn't seem advantageous to completely dry the retina. In fact, you may end up hindering reconstitution of the outer retina, at least on the OCT level, but it does seem to corroborate quite well with visual acuity and anisoconia. So the use of PFCL on our hands is to reserve it for those more complex cases that do require assistance and not for routine use, and when possible, drainage to the pre-existing retinal break seems to be and confer the best visual outcomes in terms of microstructural integrity, but also vision and less secondary complications. And that's it.
Thank you, Brian. That was...
No, I have so many questions,
All right.
But I'm just going to ask the one, which is, how do you explain the findings of the post-RD study? Because in that study, we postured patients with bubble to support the break, leaving some residual subretinal fluid. And the other group of patients were postured face down immediately for 24 hours, in both cases 24 hours. Now, if I understand what you're saying here, the group that was postured to support the break, the fluid should have reabsorbed gradually, and they should have had less displacement and less outer retinal folds. But what we actually found was the ones that were postured face down had much less retinal displacement and far fewer retinal folds and much lower risk of diplopia. I don't see how those two fit together.
Yeah, well, we've spent a lot of time looking at that paper as well and thinking about it, and this is what my assessment is. The cause of retinal displacement is a large gas bubble displacing fluid. Whether you position a patient, in the post-RD trial, everyone had a complete air fluid exchange. So if you look at the difference between groups, there was a significant difference, but there was still a high rate even in the face-down group. It was in the 30s, mid to high 30s, and in the position at the break, it was higher. So despite how you position the patient, the fact that you have a large gas bubble, that large gas bubble is going to push fluid in a certain direction in a gravity-dependent manner, and we think that the displacement happens almost immediately. So when the patient is wheeled out of the OR, you lift their head up, or you give them a coffee and a tea, or they go to the washroom because they've been lying down for a few hours, or that's when it happens. So whether you go home and do face down or position to the break, it's too late at that point. In regards to the outer retinal folds, I also think that you were still doing a complete drainage. And so regardless of the positioning, the drainage, I'm assuming, was the same. What we're suggesting is that when in that stage 2, when the corrugation's resolved, that's a slow, natural process that takes a few hours. And so regardless of how you're draining or positioning, I still think that you're going to have less time in stage 2 to allow those corrugations to go away. And so I don't think that the technique would make a huge impact on the risk of outer retinal folds. I do think that the face-down positioning, which is the very valuable piece of information from that trial, which confirmed some of the thoughts of Shiragami and others, was that immediate log roll to face down is probably the best position to minimize displacement, and many of us now are even thinking about supine positioning. The problem is when you raise the head and you move fluid to the inferior periphery is when you get stretch. If you position them immediately face down, that fluid gets displaced probably in all directions, and so you're minimizing the unidirectional flow of fluid. So I think it's very complex, and I think that was a great study, but so I think it still makes sense. Yeah.
Well, yeah, so in summary, supine face down, I think the bubble is in a neutral position with relation to the macula. So you get displacement, but it's actually sort of centrifugal rather than directional. I think that's different as I understand it.
Yeah, I think it's spreading the forces out. Whereas if you're pushing, like we saw in the PFCL case, or in a scleral buckle with drainage, if you have the direction of flow from point A to point B, and the vector force is all in that one direction, you're going to get the displacement in that direction. When you've neutralized that, you're probably minimizing the forces.
Thank you, Rajiv. I'm Dr. Dinesh Turbar from Delhi, and I must thank you and your group for disrupting our thinking, which had become sort of fossilized, and thinking afresh about the way we are managing our patients. So that's something we need to do, and I think somebody should do it every decade or so. Some questions I have. One was, you actually, during one of the presentations, somebody said that I think a significant percentage of the patients who were in the vitrectomy group were failures of the pneumatic retinopexy group. So I wanted to know whether the pneumatic retinopexy plus vitrectomy group had a disproportionate number of patients who had all these problems of displacement or not. Because this is one issue that could change the entire approach to what you're talking about. The second thing is about what Byron was saying. It makes sense that when you do drainage from a peripheral break, you can't do a complete drainage. So unless you put PFCL. If you put PFCL, you're in a better position to do a complete drainage. If you don't put PFCL, you can't do a complete drainage. So you're leaving residual fluid, and even that residual fluid seems to be enough to improve the results. That's the second thing. But the third, more important thing, as far as I'm concerned, the rate of absorption of fluid from the RPE once you tamponade a break is something like 1,000 microliters per hour, per day. Sorry, it's more or less equivalent to the aqueous drainage, 2 microliters per minute. That's enough to remove any amount of fluid that you have in a detachment, regardless of whether it's pneumatic retinopexy, regardless of whether it's a vitrectomy or if it's a buckle. So this interdigitation cannot occur that fast. It's not that it'll be very fast in a vitrectomy and very slow in a pneumatic. It'll be more or less the same, because by the end of the day, the retina would have settled down. So I don't know how much of a difference this would make, but for me, a more important thing is how many patients received an encircling band. Because if a patient who's going through a vitrectomy has also got an encircling band, that is going to cause maximum displacement of the retina, because you've completely distorted the ratio of the sclera to the retina. So these are some of the issues which we need to see, whether the proportion of patients who have this displacement is more when you have a combination of vitrectomy plus retinal detachment, plus scleral buckling in any form. It could be in a band, it could be a buckle. And whether these were patients who were failures or non-successes, whatever you can call it, of pneumatic retinopexy with vitrectomy.
So Roxanne, I'll let you answer the first question regarding the changes in the outer retinal bands, whether they were failed pneumatics that were contributing.
Yeah. No, I think the interesting thing is, of course, although the failure rate for pneumatic retinopexy is slightly higher than vitrectomy, this was a small group that we were looking at. But when we came to analyze the data, we realized that the small minority of patients that had these outer retinal changes that had undergone pneumatic retinopexy had undergone a subsequent vitrectomy. So if we were using an intention to treat analysis, we looked at it both ways. So we thought that was quite telling, but it was a small group that we were looking at.
So they didn't have that difference?
No, so ultimately, basically, anyone who had an interdigitation zone or an ELM or EZ discontinuity, they either had a primary vit or they had a failed pneumatic and then went on to vit. The successful pneumatics, almost none of them had.
No, I'm not talking of the successful.
Yeah, but
I'm talking of the failed pneumatics.
Same rate as the primary
That's the group which may have a disproportionate number of patients who had the changes in your vitrectomy group.
Right.
That's what I'm trying to ask.
Yes, right.
Because not your successful pneumatics.
But those
are
patients
perfect.
were analyzed in the pneumatic group. They were kept in the pneumatic group. If you had a failed pneumatic and then went to vitrectomy, that remained a pneumatic when we analyzed.
That's not called a.
Yes.
That's not called a vitrectomy group.
No. So the vitrectomy group is only patients who had a first vitrectomy. The pneumatic group was the patients who had primary pneumatic, whether it failed or not. They stayed in the pneumatic group. So the vitrectomy groups are only the primary vitrectomy, and even then, the risk of discontinuity was greater compared to the pneumatic group and their failures.
Okay, and the band was there. Was it there? In the
We don't use a lot of encircling band at all, but I do agree with you that the majority of the displacement is not from the change in the shape of the sclera, and we know this because if we take a primary buccal, for example, primary encircling band with no drainage, the rate of displacement is very minimal. So we know that an encircling band alone will not cause a substantial change, but if you move fluid, whether that's with the drainage or with a large gas bubble, you're going to get more displacement.
So probably the best way is to do a partial drainage.
Leave fluid and put a large gas bubble, what's going to happen?
It's still going to
You're
go
going to
off
get
in the same
displacement.
time as a pneumatic retinopexy. The time won't be too different from a pneumatic retinopexy.
Well, so there I disagree. So when you put a patient face down with a small gas bubble, the retina with OCT imaging will see that it'll reattach in about 2 to 3 hours. So it's actually very quick that it can attach. With a vitrectomy, yes, you're not getting the interdigitation zone, but you are more grossly forcing the retina to attach. And these, as Delomo has shown, these corrugations exactly lead to those outer retinal folds. So what we're suggesting is that when you rapidly drain and you don't have time in stage 2 for those corrugations to resolve, that's when you're going to create outer retinal folds with greater proportion. So it's very hard to win with vitrectomy because either on one hand, you try to get rid of all the fluid, you're going to get EZ and ELM problems, you're going to get outer retinal folds.
An alternative could be silicone oil then. Because it doesn't have the buoyancy effect.
Silicone oil will minimize
displacement.
displacement. Will minimize displacement as long as you don't fully drain. But then you have all the problems with silicone oil. So
actually, I'm a fan of silicone oil. So, but thanks to that, I mean, I don't see as much of this, and the distortion and all that you're describing. So this is.
It's because if patients can't see well, they won't complain of distortion. So when you have patients who have 20/25 vision, that's when they say that they recognize. If a lot of times patients will not necessarily complain because their visual acuity may not reach that level.
Incidentally, there was one presentation regarding the duration, which mentioned that more than 3 days causes a difference. Was there a difference in the duration of the detachment in the pneumatic retinopexy group versus the...
No, they were randomized. They were randomized, so patients is the same in both groups. But I'd love to talk to you more after as well. Yes.
Thank you. Excuse me, I just want to understand why don't you recommend face up after surgery? I
mean, for the rationale we discussed, the effect of the gas bubble is neutral in a face-down position, and we have data for that. We don't just have data for the face-down position. We would speculate that there would be advantages in the supine positioning immediately post-operatively, and indeed it might be easier to achieve, but we just do not have the data to advocate that. Yeah.
Yes.
First, thank you for the lovely session. Really enjoyed it. Just a simple question came to me. Why you did the AC tapping and the gas in the case when you did the minimal vitrectomy, not going in? Anyway, you are already in
Yes,
the back.
so why did I? Because what we found was that when we modulated the air fluid exchange, let's say I tried a 50% air fluid exchange or a 60 or 70%, I was still getting substantial displacement. It was only when I did only a 0.6 cc bubble that I was able to eliminate the retinal displacement in the minimal vitrectomy cases. And so how do I get a 0.6 cc bubble? By confirming that my eye is closed. If I keep the trocars there and I take out the trocars and you get some fluid leak, now your eye is soft. So what am I going to do? I'm going to have to inject fluid or inject more gas. So I'd rather take out all the trocars, have a closed system so that I can then reliably take out what I want and inject what I want. Exactly.
Okay. So you think it's the thing about pneumatic, or it's 0.6 gas exactly?
0.6 cc's minimum.
Yeah, I mean, it can be done, but this has anything to do with the post-op results, or?
Well, we're going to talk actually in the next session. Now we're going into pneumatic retinopexy in detail. So we're going to show you all the techniques and how you can achieve injecting that much gas. But we do believe that 0.6 minimum is a good amount of SF6 gas.
Oh, thank you.
So, thank you so much, everybody, for your attention. So we have another course actually